Good morning, good afternoon, good evening, everyone, and welcome to AI for Good, the United Nations leading platform on how to accelerate or even achieve the Sustainable Development Goals. My name is Matthias Greschel. I'm a physician and researcher affiliated with Harvard Medical School and the ITU, and I'm really pleased to open today's webinar. Today I'm joined by the main or co-moderator Enzo Ferrante, whom I'm going to introduce now. Dr. Ferrante is leading the machine learning for biomedical image computing research line in the Research Institute for Signals, Systems, and Computational Intelligence at Argentina's National Research Council. Before, he completed his PhD in computer science in Paris and worked as a postdoc at Imperial College London in the UK. With that, and no further ado, Enzo, the word is yours. Please go ahead and open today's session.
Thank you very much, Matthias, for the introduction. I'm really happy to be here. Thanks for the invitation. Actually, I'm really excited about the talk we will have today from Lelia. And I would like to directly go with that because I want her to have most of the time here to discuss the really interesting topics we will be discussing today on AI-enabled public health from a marginalized perspective, which I think is a really important topic to be touching these days. So Lelia Mary Hampton is currently a PhD student in computer sciences at MIT. Their research interests are applied machine learning for society, Black feminist philosophy of AI, and safe deployment of AI systems in the real world. They are an MIT Presidential Fellow and Alfred P. Sloan Scholar. Lelia earned a Bachelor of Science in Computer Sciences, summa cum laude, with minors in comparative women's study and mathematics from Spelman College, where they were inducted into the Pi Beta Kappa. During undergrad, Lelia interned at MIT Lab, Media Lab, Microsoft Research, Georgia Tech Research Institute, and NASA. They have helped to advance AI for health across the African diaspora with the organizations Blackathon and the Afro Computing Collective. So, wow, this is an amazing opportunity to hear Lelia here with us today. She will be talking, as I was saying before, about AI-enabled public health from a marginalized perspective. So, Lelia, thanks for being here, and please, the floor is yours.
Wow, thank you so much, Enzo and Matthias. I really appreciate it. And yeah, I guess I'll get started. Yes, so today I'll be talking about AI and enabled public health from a marginalized perspective. In this talk, I'll kind of also I'll more so be leaning towards literal AI-enabled public health, but every now and then I'll touch on how AI, even when it's not directly supposed to impact public health, even when its intention is not to impact public health, it can impact public health, whether through data practices or otherwise. So yeah, let's get started. Okay, so I first want to start with a distinction between public health and medicine. I think this distinction is important because there is a difference, and a lot of stuff has focused on medical AI. Fewer stuff has focused on how AI can impact public health, and it's also not 100% understood yet how AI-enabled public health should be done, and there are a lot of challenges therein. But anyway, so in 1988, the Institute of Medicine actually defined the mission of public health as ensuring the conditions in which people can be healthy. And this is a very broad definition, and it's not very prescriptive as to how to do public health to accomplish this goal, but it's still a very important goal. And so medicine and public health are obviously two important factors in promoting public health and promoting well-being also. And of course, medicine and public health also interact a lot and impact each other. So medical practices contribute to public health, and public health can determine what medical practices can be done. I think we've all seen this within the last few years, obviously. And yeah, so probably more on like the actual delineation and not just how they're related, is that public health deals with the population level. And a lot of what public health practitioners want to do is mitigate threats to the population health, suggest public policies, and ensure public health services. And a lot of medicine, what the goal of medicine is to kind of focus on the individual. And so to that end, medical practitioners diagnose, treat, and rehabilitate individuals. And unfortunately, there is disparities in public health. As Bassett and Lelia put it, there has not been a single year since the founding of the United States where Black people in this country have not been sicker and died younger than white people. And I think this is also true for like queer and trans people today, and even within the past century, and so on, as well as Latinx and Indigenous people. And a lot of this is related to structural issues around poverty and unemployment, subpar education, and inadequate and unstable housing. So kind of interactive effects with socioeconomic factors. And as you can see, there's like, I put a diagram at the bottom just to kind of show that comparatively in the US, a lot of people of color tend to live in poverty at a higher rate than white people, which again is a contributing factor to disparities in public health outcomes. Okay, so it is clear from history that access to being healthy through medicine and public health is not equitably distributed. And so I think it's really important to highlight public health because medical AI is obviously going to impact like millions, if not billions of people eventually. But I think that public health, the whole goal is to impact millions and billions of people and ensure at the population level that there's like adequate well-being and good and like desirable health outcomes. And I think also highlighting public health really drives home the amount of impact that you have when you're trying to actually like purposely do public health, because it is on the population level. I mean, even now, our public health goal is obviously for like literally the whole globe, which is at this point almost tens of millions of people. And so I think it's very important to do an inquiry into public health and predictive algorithms. And I think it requires a deeper investigation of social systems of oppression. Okay, sorry. I'm having trouble working the slide deck, my bad. Okay. And so I kind of want to, I guess, start with discussing a very prominent example of racism in public health algorithms that a lot of people here who are familiar with like the area may already know. And so there was a study done of an algorithm that was used so it was used for a healthcare management program, and it was designed to provide additional benefits to high-risk patients and make decisions for about like 70 million people. And so this is like an allocation algorithm for healthcare to obviously benefit like a huge population. So it impacts public health. And this study found that the system systematically denies these benefits to Black patients, despite the fact that they pay more out of pocket on average. It also gives high-risk Black patients with more chronic illnesses the same risk score as white patients. And this kind of contributes to a long historical continuum of medical racism. And obviously, if you have an issue where the Black patients are already making less, but now they're paying more for healthcare, but they're not getting the same benefits, this could actually exacerbate health outcomes. or disparities in health outcomes. So that's a huge issue. And so I think given that the algorithm impacts like 70 million people and is systematically refusing treatment to Black people, I think this situation becomes a public health issue very quickly, since it's literally at this point impacting Black people's health on the order of tens of millions, which is like an extremely large scale. And so it's also important to talk about ableism in public health algorithms. And I think one of the first things that comes to mind, and one of the things that disability scholars in this area have really hit hard on, is the privacy concerns that, which is a concern for all marginalized people, but they've really hit hard on the privacy concerns for people with disabilities, including the fact that in collecting data from disabled people, disclosing disabilities can actually impact their socioeconomic livelihoods, because it could contribute to a pay gap. If they know somebody has a disability, they might pay them less. An employer might also just flat out refuse to hire somebody who is disabled. So again, this can really impact their ability to make a living. So they might not want to disclose it, which actually impacts the quality of data in a lot of ways. So of course, there has to be policy to make sure that disabled people are being paid fairly, and that we close that wage gap. So obviously that they feel more comfortable disclosing if they want to. And I think to that end, there's just really no straightforward answer here, because algorithms do need data to be inclusive and to accurately help disabled people if they're claiming that they want to help disabled people, but sharing information could harm disabled folks. So of course there is going to need to be like a very complex answer here in terms of policy. And I think this is also compounded by issues of the lack of options to control ownership and dissemination of data. So once your data is in a database, you can't take it out, and it's not yours. You don't really have any say over it. So I think the safest option for a lot of people is to just say, I won't give it to you, because if I don't give it to you, then you can't use it to harm me. So I think that is one point in terms of the way people respond to privacy concerns. And I guess an example of some data that got out was that the ACT, which is a standardized testing service in the US, illegally shared information with universities and sold information to third parties concerning students' disabilities. Even though it's like literally illegal for them to do this, they sold it to admissions, or it was used in admission decisions, which again is illegal under the Americans with Disabilities Act. So these privacy concerns obviously are not unfounded. These are like concerns that arise from very real material conditions. So it's important to really consider them and take them seriously, and understand that it's not unfound. And so just to like kind of hit on some of the intersections between racism and ableism in public healthcare algorithms, I think one of the ones that comes to mind most readily is risk assessment algorithms, because they most often really harm people who are at intersections, whether it's like women with disabilities, older women with disabilities, older like people of color with disabilities, or even younger people of color with disabilities. And so one issue that has arisen is that there's a risk solution company called LexisNexis, and they created a risk assessment algorithm to predict the health risk of a new hire, or how much they'll cost to an employee in terms of medical inspection, or to an employer in terms of medical inspections, which is actually like very problematic. And I think another thing that ends up being problematic is that they don't actually use the individual past medical history of the new hire. They say what happens at the group level data. And I think going back to what we just said, if you already have poor health outcomes in terms of like a race, like generally has poor health outcomes. And that's due to structural issues, and now you won't hire them because they're going to cost more in terms of medical expenses. I think that quickly becomes an issue of like, again, exacerbating an already ongoing issue. And even more so, we just saw an example, like literally the first example was a healthcare algorithm asking Black patients to pay more out of pocket while receiving less benefits. So again, this is just kind of like exacerbating like issues around like systemic issues around public health, structural issues that contribute to public health. And it's not helpful in terms of that. So literally denying somebody a job because they're going to cost too much is not going to close that public health gap. But and I think another issue that arose in this situation was the fact that there were a lot of privacy concerns that arose because the company collected 78 billion records on US citizens, which is a lot of records. That's a lot of records, obviously, because billion is right there. And so they collected voter registration records, law enforcement records, educational records, information about how much debt they have, if they have any liens, information on their relatives and associates, which is guilty by association, which is not 100% good, and how many assets they had, what their education was, and their neighborhood and household characteristics. And the company cites them as social and socioeconomic determinants of health, which it is true. A lot of this is actually like a determinant of health, but I don't think that denying people jobs because they're going to cost more is going to help with tackling socioeconomic determinants of health. Like you actually need to close socioeconomic gaps to help people have better health outcomes rather than exacerbate them. And still talking about the LexisNexis situation, it's just very violent to disabled people, people with pre-existing conditions, and Black American communities which suffer more from chronic illnesses. It's, you know, it's like when you need a job and then somebody's gonna tell you they won't give you a job because you're gonna cost more in terms of healthcare. That's actually not going to help your health, the public health, or really like anybody involved in the situation. And at any rate, LexisNexis just seems to think very poorly of marginalized people based on like what they've said in their own releases, in their own report releases. So they said that voter registration demonstrates that individuals are showing engagement in their community and may be more likely to engage in their own health, and that derogatory records like liens or felonies indicate that health may not be a priority, which just goes to show that they're like not acknowledging like a socio-historical continuum. Like I think that it has become very apparent within the past few years that voter suppression in the US is still very rampant. It's very rampant among Black communities. We saw this in Georgia. We saw this in the 2016 election. We see this in every election, really, local, federal, and all that other good stuff. And yeah, so it's just, and then there's also been like the war on drugs, which is like incarcerated people. So if you want to get out and then like better your life and try and make a living to support you and your family, one of the best ways to not go back is to have an education and also to have a job, and be able to support yourself. And that's just not possible if people are denying you a job because you, and even like to say that if somebody got an eviction, you're not going to like hire them, like that's just not a solution. That's not a solution to public health, and that's not a solution to how you hire people. Like you're not going to, yeah, anyways. Oh, and yeah, so I think that I really like this quote by Olivia Banner, which is that risk is assessed then through data reflective of extractive and racialized capitalism. And I think that's very true. It seems that this isn't really meant to actually like help people with public health, but actually harm people. It just seems like it's just saving employers money, but it's also tending to harm people who are like disabled or people of color, rather than actually helping anybody involved. It's only helping the employer save money, but it's not helping them get the best employees or anything. It's not helping them, and it's not helping people like get like the work that they need to be able to have better socioeconomic determinants of public health. And yeah, and so I think another great example of an unfortunate example of racism and ableism in public health algorithms is the way that neurodiversity is diagnosed by psychiatrists and psychologists and so forth. And unfortunately, computer vision researchers are increasingly trying to use facial recognition to like automatically diagnose certain neurodiverse states, including autism. And so what they do is they actually like get already diagnosed or recognize autistic children to examine their facial expressions, their degrees of emotiveness, and repetitive behaviors, which unfortunately, all of these things are actually like related to race science, which is a whole different discussion, but like this specific way of going about it is very race sciencey. And the pre-existing framework of autism actually leads to unrepresentative data collection. So that means that the autistic symptoms, in terms of the framework that's used to diagnose already, does not reflect the diversity of the expression of autism in terms of gender, race and ethnicity, class, geography. It might manifest differently, especially it's also, it might be socio-culturally formed in some ways. Like for instance, like a Black child in the US who has autism may not have the same symptoms as a Black child in Ethiopia who has autism. And this just results in discrepancies in diagnostic rates. So basically they might be overrepresenting white like male children and not really like, the system just may not be representative of the best way to diagnose other children. And so I think that it's also concerning that these examinations have also found like little validity to like the diagnostic. So basically like their baseline is actually like not as valid as they're purporting it to be, especially when you like dig deeper. And I think another thing that they pointed out in this paper that I thought was very enlightening was just the power to be able to diagnose people is also a big power, especially given the like oppression that autistic people have faced, especially in terms of them needing to change or them needing to conform and all these other things. So sometimes like, and it's sad, but sometimes like autistic children could be safer not being diagnosed in some ways. And yeah. And so I guess this is moving on to more depressing things, queerphobia and public health algorithms. One example of this is Grindr. So they actually sold HIV status information to third parties. And the whole point of having HIV status on the app is to literally enhance the public health of queer and trans people on that app. That's literally the whole point, so that you can know if somebody's HIV positive, so you too can take the necessary steps that you need. For instance, if you need to take PrEP, if something happens, then you need to take, like prophylaxis or something to that effect. And yeah, and so apparently surveillance capitalism has just created a market to sell and distribute HIV information without consent. And it's just opened more possibilities for harms to HIV positive people, and just enabling HIV surveillance and control and stigmatization by the state and private organizations, and even the individuals that can see the status of that, obviously, because it's still stigmatized. So obviously, like, you can look at the app and be like, oh, this person said they have HIV, so I'm not going to talk to them simply because they have HIV, because people don't understand how far HIV medicine has come, and that people with HIV are still human beings and whatnot. And even to this effect, people have even used these apps to like or police specifically have used these apps to like go undercover and create fake identities to trace HIV status and then put people in jail if they like don't disclose. It's bad, and just basically criminalize those with HIV. And in general, I think dating platforms have proved unsafe places for queer people with HIV because privacy is definitely disallowed. So it really sucks that there was not privacy granted to these individuals who chose to disclose for the sake of public health, obviously, for other people's safety, to make sure that everybody involved can be safe, even themselves. And yeah. And to that end, another issue has been just the commodification of queer risk data. So like risk data surrounding who's like most at risk for HIV has been sold around the world. It's like become like a burgeoning market. And it's used for like therapeutic preventions for HIV, such as like PrEP or HIV self-testing. So PrEP is pre-exposure prophylaxis. And yeah, and so I think, again, this goes into like this idea of like who's at risk. And even the idea of who's at risk can be problematic because there's definitely been queer and trans demographics who have automatically been classified at risk for simply being queer and trans rather than them actually being a population with higher levels of HIV. And yeah, and so I think given the interest in groups who are most at risk of contracting HIV, one study found that queer risk data accrued like more material benefits. So it got them, like HIV researchers, more future grants and publications because it facilitated the interests of the global HIV biomedical industry. Because obviously there's a lot of money to be made by like developing therapeutics and medicine and all these other things. And so also another issue is that the most benefits from this research are also just going to those in the US and other Western countries and not those from the global South. And I think I like this quote by Amaya Perez Brumer, who put it very elegantly. Unique to HIV in its fourth decade, queer risk data flattens sexual and gender diversity into categories devoid of cultural and social context, obscuring the historical and socio-political dynamics of HIV vulnerability. And the contextual injustices that pattern health risks are inscribed onto biomedical identity categories and queer risk data itself, rendering structural solutions to prevent HIV inactionable, which I really agree with. I think that, again, like, as I said, like there's groups that are just kind of like, oh, you're queer and trans, so you're just at risk. And the solution becomes commodifying, again, this queer risk data rather than actually putting things in place to help people be able to prevent or get treatment for HIV. And I think that goes also back to like the stigmatization, because a lot of people don't want to work on prevention because like it's stigmatized. So then it makes it, anyways, there's a whole issue of like when you stigmatize a disease, like even we saw this with COVID, like people stigmatize COVID and then people don't want to get tested, or people want to pretend that they don't have it and then they just spread it because they have to pretend that they don't have it. So this becomes like a huge issue when you stigmatize stuff. But yeah. And so to that end, I think that it's important to talk about some of like, I mean, obviously we talked about a lot of issues in like public health so far, and some of the issues that like I've come across from like my research and like some case studies and examples and stuff. But I think just like from a higher level, talking about some issues that are either issues that we have discussed or going to be issues when we continue to think about AI-enabled public health. And like, yeah, so what are the challenges for equity therein? And so I think one of the challenges for equity is universalist design, which honestly is an issue overall in AI, is like just assuming that all users are the same. And yeah, and so I think relying on universalist design principles, AI algorithms are meant to be generally applicable. And then they use this to train the algorithms, which may only be sampled from a subset of the population. that is intended to be deployed for. And I think we got into this a little bit earlier in terms of people not wanting to disclose. There's also something called the long tail problem, where you only have very small sample sizes for certain demographics, and which is actually very common in healthcare. You can go read some of the fact papers and you can see this very readily, especially for 2021. If you go look at some of those, the ones that were about healthcare discuss this a little bit. And I think either way, that supervised machine learning algorithms take a gritty or utilitarian approach, and they exclude outliers, which is not good because, again, like, you might not have as many examples representative of disabled or, say, Black people or even people at that intersection. So this really poses challenges in terms of having accurate prediction for people who may be marginalized. And I think also, I really like this quote by Spadafore Monrad, which was, if the algorithm's goal is to emulate the performance of human raters, and in training it is penalized for not producing the same output as humans, how can it simultaneously be more objective than the humans it emulates? And I definitely agree with that, because humans are not perfect. And we also have to consider that when we're making our algorithms and making our systems and stuff like that. We can't just assume that what a human would do would always be the best thing to do. And I think that's also, it's something that's slightly, it's obviously a concern and it's a challenge, but it's something that's also exciting, that there may be a system who may be able to actually outperform a human, or may be able to like be less biased than a human. That's actually exciting in a lot of ways. And also, I think we've talked about this a little bit, like we've touched on this a lot during this talk, but another challenge for equity in AI-enabled public health is data, obviously. So healthcare data is not uniformly available across socioeconomic groups, racial groups, categories across ability. And so current data practices in healthcare don't even garner sufficient data to make accurate predictions for marginalized groups on the whole. And so I think one issue that has been, or one thing that has been proposed that is an issue in this realm, is that AI models being trained on available data rather than the data that is right is not conducive to having a adequate AI public health model. And I think even more so, we do have to still respect the fact that public health practitioners and clinicians are still learning about the full spectrum of factors that determine public health outcomes. And yeah, I think that's all I wanted to say about that. And so more on data, data must be, I think another thing is that we have to understand that, like, no matter what, these systems are not objective. Like, they're socio-technical systems. They're systems imbued with our social values, and they have to be understood as societally situated rather than an objective truth. Otherwise, like, predictive systems could suffer from like continuously self-reinforcing positive feedback loops. So we could think that it's doing the right thing, or that it's again, that it's objective, or that it's having like the best outcome, and it's completely not. And then it's harder to fix because we were like thinking that it's like God's honest truth rather than something that we socially situated. And so I think that, for example, data for surveillance sensitive cancers, such as thyroid and breast cancers, overrepresents affluent white communities, meaning that without proper care, algorithms could over-target screening to the overserved, and neglect poor communities of color, and thus exacerbate health disparities. So that is like, a lot of times, like, we really have to just think very deeply about what we're doing and not just take everything at face value. Like, we need to really understand the situation and delve deeper into situations, and not just assume that the data is everything. Like, we have to understand that the data was made by a human being. The data was labeled by a human being. Labels are not perfect. Sometimes labels aren't even expansive enough to get us where we need to go. And some of our approaches may also not even be discussing what may be the causal effect of what's going on. It may just be that we're finding associations, again, rather than causality. And I think with respect to corporate public health surveillance, special attention should be paid to massive data collection from smartphones and wearables. Like, we should really make sure that we allow people to opt in or opt out, and make sure that people feel comfortable. Because again, like, there's a lot of privacy concerns for marginalized groups, and when you have ongoing privacy concerns, they will not want to give you their data, which will obviously impact the algorithm, which will make it less accurate for them, which will further exacerbate public health. So as you can see, this is like kind of a domino effect. So we want to really make sure that everything's really tight and trustworthy there. Another concern that we have discussed previously is privacy. And more broadly, I think privacy needs to be seriously discussed when it comes to corporate data collection of public health information, and honestly, even government data collection. It requires like a critical analysis of who owns the data and the erasures of privacy by state and corporate surveillance, including drones, devices that monitor people's health and their every move, phone call, email, Twitter exchange, and more. Like, a lot of these things are monitored, and I think surveillance at this point has caused some distrust between like technologists and and just like everyday people, I guess, and people, or technologists and users. And so there is actually policy that's needed to address this. So those who experience health-related stigmas should be addressed in this policy, including queer people, trans people, Black, Indigenous, and Latinx people, people with HIV. And there is not currently the same protections under HIPAA for data protections from third parties for sources of health data. And so we should actually like make sure that there's policy for that if we're going to continue to do this. So for example, data generated by life insurance companies or by blood glucose monitoring smartphone apps are not considered protected data from third parties. But they should be. You should be allowed to opt in or opt out, and they should not be allowed to sell your data to other companies, which is obviously protected under HIPAA. Like under HIPAA, your doctor can't just give out any old health information. So this should kind of be the same for your health information, because it's actually sensitive data. So this is something that we're going to have to like address at some point in terms of policy. And another thing that's very important is transparency. We should really make sure that, you know, these systems are transparent because they are being used for public health and medicine. And there's already so much distrust already going into health and medicine. And then to add AI on top of that, which has its own mistrust factors, means that we really need algorithmic transparency. So all involved parties, including patients, medical doctors, public health practitioners, policymakers, should have access to the source code and data, and there should be no trade secrets. Right now, there's a huge issue with companies, like technology companies or otherwise, using trade secrets to say, we will not give you the source code, you cannot have access to anything. And then, for instance, like even in the criminal justice realm, people have not been able to challenge algorithms that were literally used to determine their sentence. And it's like, that violates due process. And so anyways, it just doesn't help with public trust. Like there should not be any trade secrets involved in this situation at all. And so to that effect, we also need interpretability and explainability to justify clinical decisions to health professionals, including levels of risk. You can't, and I think even health professionals say this a lot, but and even especially medical doctors, like you can't just say like, oh, you should do this. Okay, why do you think I should do that? And so yes, that's why that's important there. And so there is also inherently a transparency challenge for AI systems, especially using neural networks or even those without using neural networks, because they're intrinsically black box models, which even machine learning experts are still trying to figure out the inner workings of. And there's also sociotechnical considerations. So there needs to be a reconciliation with algorithms as sociotechnical systems, because there's like really extremely complex questions which actually cannot be solved algorithmically. You can't say we're about to solve like 400 years of like socioeconomic disparities with AI. You just can't do that. There needs to be like, of course, broader changes, including the aforementioned policy questions that I mentioned. And so I think to that extent, there's a question of how should context be handled in which interests of the clinical or the clinician and the decision maker and the patient diverge, such as when predictions are used to prioritize patients for ration services that might benefit a broader population, such as organ transplantation, disease management programs, or ICU services. And yeah, and I think we saw that at like the very beginning example where there's like an allocation algorithm that allocates extra health benefits. So obviously everybody wants those. So, or maybe not everybody, but mostly everybody's going to want those. So how do you justify that? And how do you reconcile the fact that, again, those interests have diverged? And how do we handle the allocation of limited resources in a white supremacist, cis heteropatriarchal world, given that micro allocation or the rationing based on individual characteristics is likely to play a larger role for population health and management? Yeah. And so just some closing thoughts. I think medicine and public health are fundamentally mission critical systems, so they can determine life or death outcomes. So this is very serious. Like this is not, I think a lot of tech bros are very much of the thought that like this is like cool, oh look at me, I'm making this system, I'm making this algorithm, but this is very serious. Like this isn't like something like fun and quirky to make $1 billion. Like this is like people's lives on the lines. And I think everyone deserves to have robust medical treatment and public health outcomes, regardless of any other status. And so doctors can't pick and choose, like even though in some ways they may, but that's a different story for a different day, who deserves quality medical treatment and who does not, and algorithms should not be able to make these decisions either. An inquiry into public health and predictive algorithms requires deeper investigations of social inequities, and definitely more algorithmic audits of healthcare related systems, because the full extent of the pervasiveness of algorithmic oppression in technological health systems overall is unknown. So we really have to keep digging and keep thinking about this issue. But yes, okay. And thank you for listening to everybody. I would like to thank Matthias for reaching out to me to give this talk. I would like to thank Enzo for agreeing to moderate this talk. And I would like to thank both of them for really marketing this talk like really hard. Like they marketed this talk very hard, so I really appreciate that so much. And yeah, I appreciate it. But yeah, thank you. I will be quiet and see if there's like anything else.
Well, thank you very, very much, Lelia. I also think a really insightful and amazing talk, especially for people like myself doing AI for healthcare research in general. The distinctions you made between public health, medicine, and then all the points you touched, from the trade-off between data privacy and utility, going to transparency. I mean, these are all really important points. Universality of the design, this is something we discussed a lot sometimes, whether we should go with more specific models or not. And in that sense, there is one question here in the chat that I think I will start the discussion with, and then we can also move. There are many questions from the audience, actually, which is really interesting. So Anna, is asking here, she's saying, all races may have needs for special healthcare, taking into account the differences, right? This is somehow related to this universality design point.
Yeah, no, I definitely agree. I think that there needs to be more interaction with human computer interaction researchers than there is right now, because I think that the expertise that HCI researchers bring can really inform us on how we can actually like design these systems to how do I say this, to more so cater to more diverse needs, then again, rather than saying like we're just going to universalize it and this one algorithm is actually just going to be for everybody. And I think there's also been some work in terms of people just using like different neural networks for different things anyway. I think it eventually, like, the point is for them to all to converge into one. I'm not saying that that really has to happen, but I think that we definitely need to consider how we can like, to create systems in which we could have more that cater to people's needs more. And again, HCI researchers really help in that realm because they can actually go into communities and ask what they need and be like, what do you need? What would this system look like for you? And I think this is like something that like Sasha has talked about a little bit in terms of in design justice, and especially something that Indigenous communities have been talking about for a while in terms of just making sure that design practices for systems actually center those people and like you actually go and ask them what they need instead of assuming. And I think a lot of times there's like an assumption, because if you think about, if you go look up a lot of algorithms right now, like companies don't go to users and say like, what do you need? And I think sometimes the only people that they consider also is like who's paying for it, and what do they want, and like what, or even what do I think they want. And sometimes also they're just like, well, we'll cut corners because the whole point for everybody involved is to save money and also to like maximize money. So yeah, so I think it just gets to be one of those things that's like not, that's also, I think another thing why it's a challenge is because it's not straightforward. Like, how do you do that? Like, and how do you do that for a lot of people? Because there's also still neoliberalism and obviously like capitalism involved. So there's economics involved. So again, like if you're in a situation where people want to like cut costs, but like maximize profits, then how do you incentivize them to even go out into communities and say like, you know, we're going to consider what you have to say. And yeah.
Yeah, I think this is a really, I mean, it's a hot topic of discussion nowadays, I would say, how to deal with these things, because there is also the privacy aspect, right? Like, I mean, if you want to have universality, more specific models for certain subpopulation, then you need to have access to these protected attributes somehow that you sometimes do not want to ask because they may be, you know, going against privacy issues for these people. So, I mean, it's like a trade-off that is always there, I could say. Yeah, I think these kind of discussions help to better understand these issues. There are other questions from the audience. There is Michael also, who is asking, given AI's need for data, can its use in public health give more access to voices normally excluded? This is his question. What do you think about that?
Yeah, I think that's a very good question. I think that the empowerment would obviously be up to marginalized people in terms of how to figure out how to empower themselves in terms of their data and public health algorithms. And I think also in terms of not being universalist, they could also think about maybe like public health algorithms for their communities, rather than relying on like a huge corporation who may not have a huge interest in like their individual community. I think there's a lot of ways to approach it. It could also be a mutual aid approach where it's like, we're going to figure out like public health disparities in terms of COVID in our community so that we can like try and maybe help those people. And like, it could be an opt-in and we'll make sure it's differentially private, and we'll like add fairness constraints and all these other things. But yeah, no, again, I think that like also the current data models aren't really like empowering like anybody, like including like especially a marginalized people, but it's not empowering anybody, like if you think about it. So I mean, I think there's probably a bit of mistrust on like everybody's end. And I think like until you like tackle issues of like data ownership and like again like continual like selling to third parties without consent, like these super long user agreements that nobody understands, like I think there's just a lot of issues overall even like in general, like AI practices that seep into like this area that are going to impact it that I don't know. Yeah, so I think that's a larger question. I think that it could probably be like repurposed to be empowering in some way, but like the way is not immediately clear to me.
Yeah, yeah, maybe we should think more about that, how to empower, I mean, how to use that to make these voices come out, right? Yeah, this is a really good point. There are other questions also for the audience. They are coming and coming. So I'm trying to pick like randomly some questions here. There is a question from Miriam that is going a bit more concrete, I would say. Like she's saying, could you also give some examples of mitigating strategies addressing the bias in AI algorithms? So maybe exemplifying how when you have some bias in a given system, if you could give examples, or if you think it's possible, actually, maybe that would be the first question, right? Is it possible to mitigate these biases, potential biases in some of the examples you were discussing before, and then how, if it is?
Yeah, I think that the most immediate answer to that question is that it's just an ongoing research question that we're all struggling with, because I think some of the things that are raised make it even harder. So like, for instance, like you need more data, but then there's a privacy concern. And then if you go read like the most recent fact papers from 2021, it's like, well, actually, if we do differential privacy, it makes it harder to like enforce fairness constraints, and it like, you don't get the best like fairness measurement outcomes in your output, and like you like have less robustness. So it's just like very hard. And I think like sometimes I'm like, maybe we bit off a little bit more than we could chew when we first started out and trying to make these like huge systems. So yeah, no, it's an ongoing research question that I don't have like the most straightforward answer to, because even the most like idealized things to do, like we'll make it Pareto optimal, so every group is like fair, is like, you know, it's like, well, would that really make it fair, or would it make it, is that just like something we ideologically think? So yeah, no, it's not a straightforward question. I don't really have a question. I think a lot of people like want an answer, and like we're all working towards it, but it's not immediately clear or even straightforward, because again, there's just a lot of things to like consider and think about. But yeah.
And so just handed me the speaking stick over to ask a question. Yeah, Lelia, that was awesome. I could see the paper evolve, like based on all the headers you had. I'm really hoping you'll write this down at some point for all of us to read. I'd like to ask Derek Ritz's question, which is a little bit framed as a comment, but I think entails something really, really critical. He says, sorry. It may be important to discern biases in algorithms versus biases in legislative policy, or sort of the inappropriate use of algorithms in ways that are not equitable. So yeah, sort of like biased algorithms versus using algorithms in equitable ways. What do you think about? Yeah.
You know, I'm glad that like that was Derek. Thank you, Derek, for saying that. No, like, because this is like, and I'm glad this actually goes off Matthias is what he just said too, because when I was like thinking about it, like this paper, like when I first started out, I was like combining things, but it's very clear, like, and that's kind of why I started off the talk, like just prefacing like this is going to cover multiple things. It's not separated yet, but yeah, no, this is definitely like has to be like separated into multiple papers and multiple topics, because it is different, like or it's not even like necessarily different, like it overlaps, but you do have to be very intentional about the ways in which it overlaps and not just conflate stuff. And I definitely agree with Derek. I think that's like, just to get like on my high horse right now, a huge issue right now in just the overall like literature of like AI as socio-technical systems. Like a lot of people tend to conflate and overlap and like yeah. So that's that, and that was one of the reasons why like I like think that the Obermeyer example is like perfect in terms of that study, but I think it is like obviously like used in places where like people conflate its relevance to like what they're actually talking about. So no, I definitely agree with that. And I think like it's a good point. But obviously policy is also inextricable from thinking about like AI systems, because first of all, there's just not a lot of policy governing them in general. And we do need to think about how how we should govern them. And I definitely agree that like, again, like, I think that's why I prefaced it at the beginning. I'm like, this is like two things. So it's like literally like intentionally like people who made AI to like for public health purposes, but also like how AI has like impacted public health just in general. So no, that's two separate topics, and that it will be like split up eventually. I just didn't do it in this talk, but it will be split up eventually. Yeah.
Thank you, Lelia. I'll ask one more question and then I'll hand it back over to Enzo. I'd like to ask Mirsad Karami's question, who's showing or writing some data about the ethnicity of data scientists based on towardsdatascience.com estimates. So data scientists are almost 50% white, only 4% Black. How do you think this affects how data science, how AI is sort of biased?
Yeah, so I guess like the quickest thought that I have is that first of all, there's inequitable hiring, which has been like talked about recently in terms of like companies purposely not hiring like Black and Latinx people and Indigenous people and like purposely thinking that they're unworthy to be there, like the hiring people or the interviewers and the hiring managers and stuff like that. I think another thing is that representativeness is something that can help, but it's not something that necessarily helps because, for instance, I don't know if this is a good example. Atlanta, like the mayor is like, you know, somebody who has not necessarily, who has, okay, so the mayor for the past few years was Black, but then they weren't necessarily progressive towards Black people. So I think it's like necessary to like understand that there does need to be a diversity of voices, but I think it's also like critical to understand also that those diversity of voices may not also have the benefits of like the demographic that they may claim to represent. So yeah, just a quick, I hope that was quick, but yeah.
Back to Enzo.
Well, and I think, I mean, there are many more questions. I am really sorry that we cannot ask all of them because we need to close, I guess, in 3 minutes. But just as a last one, there are people here from a charity called Privacy International, where they are working in the intersection of human rights and technology. And basically what they are asking is, where can they identify or where are continuing to identify, where can we do change? Where do you think are the key pressure points or policy initiatives in this relation between human rights and technology that can use as a leverage to get the protection needed to protect the people, basically? So
oh, wow,
this
that
intersection.
is such a good question. That is such a good question. It's such a heavy question. I don't know that I have like an immediate answer. I think probably the most immediate answer is understanding. First, I think there needs to be like a diagnosis, like understanding like why stuff isn't trustworthy, understanding why people don't want to give them their data. Why are there like socially inequitable outcomes in terms of like AI enabled public health algorithms? I think all those like need to be addressed. So there needs to be a diagnosis. And I think also, again, like I think addressing like privacy and like data ownership concerns is like one of the key pressure points. And again, like back to Universal's design, like really showcasing more stakeholders. I think one of the issues is that, again, like everything tends to be so profit centric that it's hard to do stuff when profit is the ultimate goal rather than like more of a like Rawlsian, let's help people, let's have a socially let's put social welfare first. So I think that we need to stop putting profit first and put social welfare first and put people first. But yeah.
Well, with this, I think we will be closing, right, Matthias? I want to thank you, Matthias, for the invitation to moderate and to discuss with Lelia. It has been such an insightful morning for me. So yeah, if you have some closing remarks or wherever, just go ahead.
Yes, thank you, Lelia, for an amazing talk. Thank you, Enzo, for being an amazing moderator. And we have prepared a small poll for all the attendees to let us know if you'd recommend listening to another webinar on the AI for Good platform. Please type in your response. And I'd like to reiterate that this AI for Good platform, and especially now the AI and Health series, I really would like to see it being a really open platform. Enzo and Lelia have also now kind of joined the team to propose new speakers and be moderators. So please, if you have any colleagues at your department, or some non-for-profit, or anyone who we should feature on this platform, please reach out. You can find my email or the AI for Good email on the internet. This should really be open for everyone, and I really hope to feature content and talks highlighting challenges in AI research, which maybe don't get as much attention as they should. With that, please keep your eyes open for the next talks. We're preparing an amazing and super interesting lineup for the coming months. And that's all. Thanks again to the speakers and moderators. Thanks to all attendees. Have a good rest of the day. Goodbye.
Rewind selector, rewind selector, rewind selector. Rewind selector, rewind selector.